This lecture is on bacterial endocarditis in veterinary species. Bacterial endocarditis is also known as infective endocarditis or vegetative endocarditis, the latter term coming from the lesions that develop on the valves that almost look like vegetables or color flower appearance. Bacterial infection of the endocardium most often happens on the valve itself, called valvular endocarditis, but can happen on the inner surface of the myocardium, and then it's called mural endocarditis. Overall, there's a low incidence of bacterial endocarditis in veterinary species, and the diagnosis of bacterial endocarditis constitutes less than 1% of all cardiovascular diseases in dogs. It's even less common in cats, although bacterial endocarditis may be more commonly diagnosed in ruminants and horses. Infection, which localizes on the valve, leads to proliferation and fibrous changes of the valvular tissue. These vegetative lesions can create either stenosis of the valve, insufficiency of the valve, or both. Valvular insufficiency is more common than stenosis, although some animals have both stenosis and insufficiency. Each species has their own bacteria that are particularly likely to create bacterial endocarditis. In the dog, strep, staph, E. coli, as well as certain Bartonella species can lead to endocarditis, with similar organisms in the cat. In the horse, strep equi or streptoepidemicus has been reported, as well as actinobacillus. Cattle may develop streptococcus, carinobacterium, or other organisms. In the dog, the mitral valve is the valve most frequently affected with endocarditis, followed by the aortic valve, while valves on the right side of the heart are much less commonly affected. The same is true in the cat, although aortic may be seen approximately equal frequency to the mitral valve for endocarditis. And similar would be identified in horses, whereas in cattle and some other ruminant species, the tricuspid end or pulmonic valve are seen to be affected with endocarditis more frequently than the mitral or aortic valve. This picture shows a region of normal aortic valve and another portion of the valve that's affected by bacterial endocarditis with a vegetative lesion on that valve. Here's the heart. It's opened up of another animal, a large animal that has a relatively fresh vegetation on the atrioventricular valve. One of the ways to get bacterial endocarditis is to follow a proposed pathogenesis that involves 4 factors, and this is sometimes referred to as subacute bacterial endocarditis, or SBE. These factors include a previously damaged cardiac valve, which then has a sterile platelet fibrin thrombus that develops on the damaged valve. The animal then experiences bacteremia, and especially if there's a high titer of agglutinating antibody against the organism, this can set up the situation for ideal development of bacterial endocarditis. This does not have to happen in all situations, but it's one of the proposed mechanisms. Bacterial endocarditis can occur, and in dogs and cats probably most frequently occurs on normal valves due to highly pathogenic bacteria. Certain bacteria, like Enterococcus and Streptococcus, can adhere to cardiac valves, and others can produce proteases that may lead to valve injury and facilitate colonization of the valve. Thus, pre-existing valvular pathology is not required, although in the dog, pre-existing subaortic stenosis does seem to be a predisposing factor for development of bacterial endocarditis. So, pre-existing valvular disease, especially congenital subaortic stenosis in dogs, and congenital disease may be present in up to 10 or 15% of dogs with bacterial endocarditis, with subaortic stenosis being the most frequently identified pre-existing congenital disease. Some animals that develop bacterial endocarditis have been on immunosuppressive drugs for some period of time before the point of diagnosis, or they had recent surgery or a recent IV catheter placement. For dogs, middle-aged, intact, male, large breed dogs appear to be predisposed to the development of bacterial endocarditis. And many animals have a history of antimicrobial use, although this antimicrobial use may be for a short period of time and might not be directed at the offending pathogen. An allergic factor has been proposed for certain forms of endocarditis, including in horses. When the mitral valve is affected, that can lead to mitral regurgitation, which may create a systolic regurgitant quality murmur. If mitral stenosis develops, a very soft diastolic murmur may be noted. And mitral valve endocarditis can lead to signs of left-sided congestive heart failure with pulmonary edema. When the aortic valve is affected, there is aortic regurgitation, which can result in a diastolic decrescendo murmur with bounding arterial pulses. If aortic stenosis also develops, you may notice a systolic ejection quality murmur over the left side of the heart base. And aortic valve endocarditis can also lead to left-sided congestive heart failure. When the pulmonic or tricuspid valve is affected, we may see pulmonic and/or tricuspid stenosis or insufficiency leading to right-sided heart failure. And these animals are more likely to get pulmonary thromboembolism rather than systemic embolism, which we'll talk about shortly for the left-sided cardiac valves. So the systemic effects can be a result of either bacteria being shed from the valves into circulation or thrombi breaking off of the valves, leading to local infection and/or infarction. And if a thrombus that does not contain bacteria breaks off of the valve, it could be referred to as a bland thrombi. So as bacteria shed off the valve, that can lead to urinary tract infection or pyelonephritis. Or if it goes to the central nervous system, we can see meningitis or encephalitis. The joints seem to be affected with some regularity, which can lead to a septic polyarthropathy. And we can also see myocarditis. When thrombi are shed for the valve, that can lead to infarction of the spleen, kidney, left ventricle, or other organ systems, with the spleen and kidney being commonly noted to have infarction associated with bacterial endocarditis. The approximate combined incidence of non-cardiac organ involvement in dogs can be quite high, and this is part of the challenge for establishing a diagnosis for endocarditis. Up to half of the dogs or more may have evidence of kidney disease, and neurologic signs or arthropathy may be noted in 25 to 50% of dogs. Abnormality of the spleen may be present in a significant number, and changes in liver enzymes or evidence of hepatic dysfunction may be present in up to a third of dogs. Overt arterial embolism to a peripheral limb may occur less commonly, but can be seen, as any organ can be affected by thromboembolic disease. And pneumonia can develop, but may be more frequent with right-sided bacterial endocarditis affecting the tricuspid or pulmonic valve. Here's a picture of the back of a retina showing evidence of hemorrhages from an animal that had endocarditis. And here's a diagram that may help depict some of the changes that we can see in an animal with endocarditis. So if the aortic valve is affected, we may see turbulent flow in systole due to a stenosis or diastolic murmur as a result of leak at that valve. And if the mitral valve is affected, we're especially likely to see mitral regurgitation with a regurgitant quality murmur over the left apex of the heart. Bacterial endocarditis can sometimes create a significant inflammatory response on the part of the host's body. And these immunologic effects can complicate establishment of the correct diagnosis. This immunologic reaction can lead to diseases that mimic immune-mediated diseases, such as immune-mediated polyarthropathy or glomerulonephritis. In addition, certain immunologic tests, such as the anti-nuclear antibody, the Coombs test, or rheumatoid factor, may develop a positive test in the face of bacterial endocarditis, even though there is not a disease process that would benefit from corticosteroid administration. So there are a couple of clinical scenarios that may be seen with endocarditis. The first of which is congestive heart failure, which might happen in up to 50% of dogs and probably a larger proportion of cats. And since the mitral and aortic valve are most commonly affected, that typically results in left-sided heart failure. The next major clinical scenario we may see is fever of unknown origin. So an animal presents with fever, and a preliminary workup with laboratory testing and certain diagnostic imaging fails to identify a source of the fever, and these cases are noted to have fever of unknown origin. The next main category of clinical scenario would be multisystemic signs suggestive of either infection or immune-mediated disease. And in fact, many animals that present with bacterial endocarditis are thought to originally have immune-mediated disease or infection that does not affect the heart. And the last clinical scenario would be evidence of organ embolism as the main presenting sign. Common clinical findings in horses can include depression, weight loss, and poor body condition. Bacterial endocarditis has been more frequently diagnosed in younger middle-aged horses. There may be a mild male predisposition. The majority had fever, murmur, tachycardia, and tachypnea or dyspnea, with lameness or synovial distension noted in up to half, and elevation of fibrinogen, leukocytosis, neutrophil count, as well as hypoalbuminemia and elevated globulins may be seen as well. Anemia may be noted, and elevated alk phos may also be seen in horses with bacterial endocarditis. Common findings in cattle can include recurrent fever, dyspnea, or epistaxis, with weight loss, decreased milk production, tachypnea, tachycardia, or anorexia in the majority of cases. Fever, cardiac murmur, congestive heart failure, lameness, and arrhythmia are less commonly noted, but may signal the potential for a cardiac cause for the clinical signs. The right-sided heart valves are more commonly affected in cattle, with the pulmonic and tricuspid much more frequent than the mitral valve. Echocardiography can be used to identify the vegetative lesion, like it is in other species, and common laboratory abnormalities include leukocytosis, neutrophilia, anemia, low albumin, and elevated globulins. Common clinical findings in cats can include lameness or arterial embolism, as well as dyspnea. The median age in one report was 9 years of age, with no clear breed or sex predilection. Cats may have fever, lethargy, weight loss as relatively non-specific findings, and some may have a prior suspected infection, but only 3 cats were febrile at the time of diagnosis in one case series out of 13. Murmur was present in the majority of cases, as was congestive heart failure, and the aortic valve or mitral valve were more commonly affected. Laboratory abnormalities in cats with endocarditis and with sepsis in general are maybe less consistent than with some other species, but neutrophilia, anemia, hypoalbuminemia, azotemia, and increased bilirubin may be noted. And as is probably true in most species, the median survival time after diagnosis of bacterial endocarditis is relatively short. So animals may have vague presenting complaints or clinical signs that might include lethargy, anorexia, depression, cough or dyspnea, lameness, especially in intermittent shifting lameness. And in dogs, they may be middle-aged or older large breed dogs, and males are predisposed. Recent bacteremia or a recent surgical event or recent placement of an IV catheter may be noted. And immunosuppression or prior cardiac disease may be part of the history. It seems that myxomatous mitral valve disease probably is not a main predisposing factor for development of bacterial endocarditis. Common clinical signs in dogs with bacterial endocarditis can include fever, leukocytosis, cardiac murmur, especially a new cardiac murmur, or lameness, especially a shifting leg lameness. Although if you're hoping to see many of these findings, you might be disappointed. In one case series, the combination of fever plus leukocytosis plus murmur was only present in 44% of dogs affected with bacterial endocarditis. And if you add lameness into it, it appeared that it was only 18% of dogs that had all of the findings of fever, leukocytosis, murmur, and lameness. So a new or changing cardiac murmur might herald an interest in the potential for a diagnosis of bacterial endocarditis. And diastolic decrescendo cardiac murmurs in dogs and cats are often associated with endocarditis. A diastolic decrescendo murmur as a result of aortic regurgitation can be seen in horses with bacterial endocarditis, but in older horses, it more likely signals degenerative aortic valve disease. And if there's significant aortic regurgitation, you may find bounding femoral arterial pulses. So here are some of the auscultatory findings that may be noted with bacterial endocarditis. It's possible to hear a diastolic decrescendo murmur. This murmur is often very soft and sounds like a soft hum in the background. Again, this would be a result of aortic valve insufficiency. If the aortic valve is stenotic, we may see a crescendo, decrescendo murmur. If the mitral valve is affected and there's mitral regurgitation, we may see a regurgitant quality murmur during systole that's usually loudest at the left apex. And in animals that have both aortic stenosis and aortic insufficiency, we may hear a to and fro murmur, which has a systolic ejection quality murmur in addition to a diastolic decrescendo murmur. Laboratory findings that may be seen in dogs can include hypoalbuminemia, increased alkaline phosphatase, increased ALT or AST, elevation of kidney values BUN or creatinine, high or low blood glucose, in addition to increased globulins or increased bilirubin. Abnormalities on the complete blood count in dogs might include leukocytosis, neutrophilia, a left shift with band neutrophils. Monocytosis is relatively common, and toxic neutrophils, thrombocytopenia, or anemia may also be seen. On a urinalysis, you may find evidence of bacterial infection or CAS, and hematuria, proteinuria, or bacteriuria may be noted. Since bacterial endocarditis is a systemic disease and has the potential to lead to disseminated intravascular coagulation, coagulation testing may be appropriate, and you may see changes in the prothrombin time, activated partial thromboplastin time, fibrinogen, D-dimers, and thromboelastography testing may also identify coagulation abnormalities. Especially in animals with culture-negative endocarditis, Bartonella serologic or PCR testing may be appropriate. Studies to look for immune-mediated disease are commonly done, as these cases can mimic immune-mediated disease processes, and sometimes those tests will be positive, leading to a misdiagnosis of immune-mediated disorder. And you may want to tap a joint, arthrocentesis, to look at both cytology and culture to see whether there might be a polyarthropathy or a septic arthropathy present. Electrocardiographic findings are common, and in dogs, some arrhythmia is noted almost half the time, including ventricular arrhythmias, atrial arrhythmias, AV block, which can be third-degree AV block in a handful of cases, or ST segment depression secondary to ischemia or myocarditis. Here's an electrocardiogram from a cat with bacterial endocarditis that has multiform ventricular premature depolarizations. We have a LV origin VPC here and a right ventricular origin ventricular premature beat here. There's evidence of delay in AV conduction, as well as some ST segment depression and ST segment slurring, and a prolonged QT interval. Here's an electrocardiogram from a dog with endocarditis that had advanced AV block in association with endocarditis. There's both junctional escapes and ventricular escapes on this electrocardiogram. These beats originate from the ventricle, and again, there are multiple P waves here that are not conducted down to the ventricle, indicating advanced AV block. Radiographic findings are variable. Usually we'll see left heart enlargement more so than right heart enlargement in dogs and cats. We may see evidence of congestive heart failure with pulmonary vein distension, interstitial or alveolar infiltrates, especially in the perihilar or caudodorsal region. It's possible to see evidence of pneumonia, especially an alveolar pattern in the cranioventral region of the lung. And pleural effusion may be noted in a small number of cases, or you may see findings suggestive of pulmonary thromboembolism. These radiographs are taken from a dog that had bacterial endocarditis in association with the aortic valve. No evidence of heart failure on these films, but this was a dog that had mitral valve endocarditis, and there was evidence of both congestive heart failure as well as potentially additional pneumonia from this cranioventral distribution. Echocardiography is very valuable in establishing a diagnosis of bacterial endocarditis. We can see thick, asymmetric, shaggy, hyperechoic, or bright vegetative lesions on the valves. These lesions often oscillate, are vibratory, or mobile during the cardiac cycle. Cardiac chamber enlargement or hypertrophy may also be noted with valvular regurgitation or stenosis. Echocardiography is fairly accurate, identifying endocarditis when it's present with a purported accuracy of 80 to 90%. Transesophageal echocardiography can also be done, and this may allow better definition of structures at the heart base and may improve diagnostic accuracy, although transesophageal echocardiography requires anesthesia in order to accomplish in dogs and cats. Again, this picture here on the right shows an open left ventricle with the normal aortic valve region here, the aorta, and then a vegetative lesion on the other aspect of the aortic valve. Again, we have the left ventricle open here and the vegetative lesion on the aortic valve. This is from another dog that had endocarditis of the aortic valve. And again, this is the left ventricle here, the aorta, the aortic valve is moving in a chaotic, highly oscillatory fashion. And on the right-hand panel, you see aortic regurgitation as well as evidence of aortic stenosis. This animal had mitral valve endocarditis affecting the mitral valve, and you can see a large vegetation on both of these views. On the left-hand panel, you can see a thick oscillating structure that bounces back into the left atrium from the mitral valve. And again, you can see evidence of that on this parasternal long axis view on the right side as well. So again, as a summary, common clinical findings in animals with bacterial endocarditis can include fever, new or changing cardiac murmur, non-localizing or multisystemic signs, including a shifting leg lameness, monocytosis, thrombocytopenia, neutrophilia, toxic neutrophils, low albumin, increased liver enzymes and/or elevated bilirubin, cardiac arrhythmias or persistent sinus tachycardia, or potentially evidence of thromboembolism. No animal is going to have all of these findings, and one needs to maintain a high index of suspicion for bacterial endocarditis if one is to establish a diagnosis. You need to know that a handful of these findings should cause you to try to obtain an echocardiogram in addition to blood cultures. So cultures are really needed in order to establish a definitive diagnosis of bacterial endocarditis. And the organism diagnosis might be established 50 to 80% of the time on the basis of culture. There's a handful of cases that are culture negative, and especially on these cases, we should think about Bartonella. So joint cultures would be supportive of a diagnosis of bacterial endocarditis, as are urine cultures, but really the answer is in a blood culture. And you'd like to get both aerobic and anaerobic blood cultures after a sterile prep of the skin. And you'd ideally like to get 3 sets of blood cultures 30 minutes to 1 hour apart. And you'd like to get these before you give antibiotics. So you do the first blood culture, you wait 30 minutes to an hour, you get the second one, you wait 30 minutes to an hour, you get the third blood culture, and then you start broad spectrum antibiotics. And there is some thought that maybe in the future PCR could help diagnose infection instead of a blood culture, but at this point in time, blood cultures are really the way to try to establish a diagnosis of bacterial endocarditis. So here's a picture of the neck prepared, the jugular vein standing out. We're going to get a sterile sample of blood from the jugular vein. We're going to change the needle, and then we're going to inoculate the culture tubes. And it often takes several days for the organism to grow from a blood culture. So Bartonella species can lead to endocarditis. Usually in animals that have Bartonella endocarditis, the aortic valve is the most common location. And typically for Bartonella endocarditis, there is not another bacteria that's part of the picture. It's just Bartonella. And in one study, 20 to 28% of the canine endocarditis cases were due to Bartonella. And so a titer or PCR testing may be helpful to establish a diagnosis. Because of the difficulty of trying to establish a diagnosis of bacterial endocarditis in dogs, a scheme has been developed, modified from the Duke criteria, which are used in people to try to establish endocarditis. This modified Duke criteria for dogs helps to support or refute a clinical diagnosis of bacterial endocarditis and is broken down into major criteria and minor criteria. And a similar process could probably apply to other species, although this particular criteria does not work that well in cats. So the major criteria, the first one is a positive echo finding suggestive of bacterial endocarditis. The second major criteria would be positive blood cultures in the absence of another obvious source of sepsis. And the third would be a recent onset diastolic murmur and evidence of more than mild aortic regurgitation. The minor criteria are fever, large breed dog, new or worsening systolic murmur, in addition to evidence of embolic disease, immunologic disease, or subaortic stenosis as a pre-existing condition. So in trying to use these criteria to identify is it endocarditis, you could say that it's very likely endocarditis if you have a combination of pathologic criteria, such as microorganisms identified on culture histology and vegetation, or clinical criteria from the previous slides with 2 major criteria, or a positive echo finding plus 1 minor criteria, or at least 3 minor criteria. So once we've established a diagnosis of bacterial endocarditis, what do we do next? Usually there's a long course of antibiotics for a 4 to 8 week period of time. We typically treat for at least 6 to 8 weeks and then repeat the echo to identify whether there's change, resolution, or shrinking of the lesion before stopping antibiotics. The antibiotic choice is best directed on the basis of culture and sensitivity or other testing. And usually we'll start with broad spectrum antibiotics, usually a combination of ampicillin with amikacin or imipenem or meropenem. And ideally we would give intravenous antibiotics for the first 3 to 14 days when possible. Even if immunologic tests come back positive, corticosteroids are contraindicated, and more than one study has shown reduced survival for animals with bacterial endocarditis that are treated with corticosteroids. So again, here are some ideas on initial treatment choices, depending on where you think the organism is from or what the most likely organism might be. The prognosis for bacterial endocarditis is not especially good, although if the disease can be caught early and the valve destruction is not extensive, the prognosis is probably better. One study identified a median survival of only about 50 days, although some dogs lived a very long time. Animals with aortic valve endocarditis lived shorter than dogs with mitral valve endocarditis. And the prognosis was worse in animals that already had congestive heart failure at the time of diagnosis, if the aortic valve was affected, if they had a gram-negative organism, if they had kidney failure, thrombocytopenia, or thromboembolic complications, and if they were treated with corticosteroids. Less information is available with regard to the prognosis or survival time in large animal species and cats. This, of course, brings up the question, is there a way to prevent bacterial endocarditis? This is a very difficult disease to diagnose. It's a difficult disease to treat. It has a relatively poor outcome in many cases. So people have recognized there are certain situations where bacteremia may occur. And perhaps if we know the situations where bacteremia can occur and we give antibiotics, we would reduce the chance for an infection to develop on a cardiac valve. So the restrictions on when to give antibiotics for certain situations have developed over the last 10 or 15 years on the basis of trying to calculate the risk to benefit ratio. How many animals need to be treated in order to prevent one case of bacterial endocarditis? And how does that number needed to treat in order to prevent endocarditis compare to the number of individuals that might experience a significant adverse reaction like anaphylaxis to the antibiotics? On the basis of this calculation, the recommendations have been to be a little more sparing with when you would give antibiotics to try to prevent bacterial endocarditis, despite the fact that there's a number of different clinical situations that can lead to bacteria in the bloodstream, such as dental extractions, gastrointestinal or urinary procedures, and other medical interventions. This is some of the literature that I used in this talk.